All right, there it is. What is up, everyone? It is the Critical Care Lounge. My name is Haney Malamat. I'm joined by the always handsome, always debonair, Dr. Adam Green. What's up, my guy?
I'm getting the butterflies.
Are you?
You know
Why is
that feeling? I felt like this is our 11th episode, and I felt like I was in a good zone. I felt comfortable on the air, and we
In the
had a
groove?
little break. And I'm not going to lie. I got nervous before tonight. I was
Really?
feeling it again. Yeah.
You know, Adam, there's nothing to be nervous about. As they say, you just picture the people in front of you naked, and it should put you at ease.
That's right. That's right. I just
Does
have
this
to
put you at
remember,
ease?
you're the guy who knows things. I'm the guy that acts like I know things. As long as we got our roles right, we're ready to rock, right?
I think so. And tonight we have a really, really good show. It's a show that people have been asking about. So we do on the Critical Care Lounge, we deliver. Adam, what do we got tonight?
Before I tell you, although I guess it has been posted, so everyone knows, so it's not a surprise. I'm really excited about tonight because this is a little different. It's something that we probably don't talk about all the time. I've never heard of a show about this, but at the same time, I think we all experience it on one end or the other. So we're going to be talking about transporting the critically ill, and we are very fortunate because we're going to talk about both the EMS perspective, i.e., going into the community to try to bring patients back to the hospital, and from the medical transport, i.e., ICU to ICU. And so we have two amazing guests. Is it okay if I introduce them now, or should we bring them
Please,
on?
let's bring
How do
them
we do
on.
it? So we have two amazing guests. One is Dr. Jerry Carroll. He is our own Cooper ER physician who has done a fellowship in EMS and is the medical director of the program and the program director of the fellowship. So I am so thrilled to have Dr. Carroll on with us. And then we also have, I just met her about an hour ago, and I feel like we're already close friends, Dr. Ani Aiden. And she is, correct me if I'm wrong, she's at Yale. She is an ER doc, surgical intensivist at Shock Traumas, where she trained, and is the director of the medical transport at Yale. Is that correct? What I miss?
The critical care transport, right?
Cool. Critical care
And
transport.
she's also good friends with my sister. That's just some
Sure.
random information for you to know.
Sure.
So there you go.
And I didn't even know you had a sister. So this has been an educational night so far. Great. So let me tell you who I am. I'm an intensivist who knows nothing about this topic. So with that said, I'm going to jump into the first question. This idea of transporting the critical ill really is foreign to me. I know that there are standard transports, i.e., a regular medical patient maybe going for an elective procedure, and I know that there's transporting where you have critical care equipment. What is the difference? How do we divide this world of critical care transport?
Yeah, so I can talk about that a little bit. I mean, I think one of the painful EMS sayings is if you've seen one EMS system, you've seen one EMS system. So a lot of this is knowing what you have locally. But it has to do with the provider training level, both certification wise, and then also what specialized training they have at whatever hospital or service they work for. So at on the initial rung will be an emergency medical technician, who is the kind of the backbone of our EMS system. It's most units that you see. And that will be followed by paramedics who attain that level of training, then go on for another 2 years of training. And then you'll have our critical care nurses. And each state will do a little bit of different things with that. But all of those training levels really need to be stepped up for critical care transport, which is why it's so important to really talk about what you need when you're transferring and then know what your local resources are. Hope that wasn't too vague, but that's probably the reality.
No, that was good. And when does the physician play? Like when is there a physician that follows the transport? How does that work out?
Now, when you say follows a transport, do you mean is involved, like physically in the
Yeah,
transport?
involved,
or...
physically involved. Like, or is that really just at the EMS level?
So, do you mean actually going on the transport? I'm just going to clarify.
Yeah.
So they can, and there's different models. Just to borrow from what Jerry just said, if you know one critical care transport program, you know a total of one critical care transport program that extends onto that world as well. There are some critical care transport programs where a physician is actually part of the transport, literally in the back of the ambulance or on the helicopter. And there's some where, for example, I'm the medical director and I will have some oversight and I will be available via phone at any time if the crew needs me, but won't physically go on the transports.
Right. Right.
So let me ask you a question. Adam and I and other attendings accept a lot of patients. And we ask things when we're getting the phone call. Is the patient hemodynamically stable? What pressures are they on? What have they done at the outside hospital? You coordinating the transport between the two facilities, are there other key questions that we should be asking to really ascertain the safety of that patient in transfer? Because ultimately, the transporting hospital or the hospital requesting transfer just wants to get the patient out of there, but it falls on the people who actually bring the patient to our hospital. There may be some key things that we should be asking. What are some of the normal things that you like your transport professionals to ask or know before they engage in that transfer?
I think to answer that question, Haney, I think it's important to understand the roles that the different providers play. I think take like a step back, I think we need to understand what the sending provider's responsibilities are, what my role would be as a medical director of a transport program, and then what are the responsibilities of the receiving provider. So as the sending provider, they actually bear a pretty great deal of responsibility when it comes to transporting a patient, whether critically ill or not, interfacility, intercampus. So the sending provider is responsible for performing a medical screening exam. That's part of EMTALA, ensuring that the patient is stabilized before transport, and then actually dictating and identifying the need for transport, but also the level of transport and the mode of transport required. In other words, is it, as Jerry was saying, just a basic BLS transfer with EMTs? Do they require a paramedic, an ALS transfer? Or do you need a higher level with critical care transport? Is ground okay, or do you need to go air? So that's the sending provider who's going to make all those decisions. As the medical director, I am responsible for the scope and the training of my crew, and I'm there to support that team during the transport. And then it's the receiving provider who provides the expertise, number one, assuming that this is a transfer for higher level of care, and also ensures that a bed is available for the transport itself. So it really depends on the system in which you work. So to answer your question very specifically, if in some institutions, for example, what I have set up in my home institution at Yale is that our receiving ICU docs actually play a pretty critical role in our critical care transport because it's an extension of our hospital in essence. And therefore, our team, our critical care transport team, can actually call our receiving providers and ask for guidance during transport. That's not true in all institutions. So you really need to know the environment in which you work and how much responsibility you have for the transport.
Gotcha. Jerry, what do you think? What are some of the things that you tell your professionals before taking a patient? Because once they leave, they're on that rig and they're on their own, and you want to set them up for success.
Yeah, I think even stepping back before we talk about that, I mean, everything that we just outlined is EMTALA, right? EMTALA kind of set up the rules that we have for this, and the vast majority of those responsibilities are on the sending physician. The danger there begins that usually the sending physician, and I'm an emergency physician, so I kind of identify with this when I'm at some of the tertiary community hospitals that I've practiced in, is sometimes they're not as well versed in what needs to be done, and so part of that accepting conversation, if done well, talks about what can and can't be done before sending, what are the safest things to get done, and then also what parameters are you looking for, right? And a lot of that gets lost, either not talked about, because at the end of the day, the physician sending is often trying to get back to other patients, other priorities. They do just want this patient out. You, as the intensivist, are getting more work, less excited about that, and want to get off the phone and get back to your patients. And so that conversation is not always done as well as it could. And EMS is not always part of that conversation and kind of inherits this middle ground that's gray. And so I think what we talked to, having an internal system like the Yale one is great, where EMS can actually call back to get those recs that might not otherwise have been given. But I think in a system where that's not possible, you really need to focus on that physician to physician conversation so that information is relayed, right? I want these, here are the 5 drips you have on. These 2 are essential. These 2 are not. Yep. These are the vital sign parameters. should we take that airway before you go? If do we have a critical care? Do we have a critical OB patient who is in preterm labor? Is that safe to transfer? And we could talk about that for ages. Depends a whole lot of what on the service you have. So I think that conversation is almost more important. And then, so like I said, I think every intensivist, every accepting surgeon needs to know who's going to pick up the patient they just got, so they know how to help. And I think it's the same thing locally. We can't just, as EM docs, be like, I'm done, let's get this patient out. How, we have to, because often that EMS will show up and only talk to the nurse. And so there's a lot of information missed there.
Oh man, there's so much I could piggyback off that. So tell me if I'm wrong. I'm gonna make two statements, and tell me if you agree or disagree. I sure hope you agree. So, and it's a mistake that I see during that conversation on both ends. So the mistake I see on the sending doc is I feel like when I answer the call, it's like a sales pitch to me. Like why they need to send this patient. And I frequently want to say, hey, like, I'm going to accept this patient. Like, you don't have to pitch it to me. Like, we're going to bring them over. You're asking for help. I can help. That's enough for me. I don't need any more. Right. And so I would love it if people just like tell me the truth of exactly what's happening. Cause that's a mistake on their side. And the mistake I see on the accepting side is this desire to give advice. And Haney, I don't know if you agree with this. Like I'm on the phone. I like to make sure they're relatively stable, and then I usually stop. Like I don't tell an ER doc that they should intubate the patient. They know if a patient should be intubated or not. They're standing next to the patient. I'm not standing next to the patient. So I see that there's sometimes this desire to give like over advice. I don't know what you guys think about that.
Yeah, so I have a lot of opinions about that because I've sat on both sides of that conversation. I think the biggest thing is, as the transferring doc, is having the humility to say you need help when you call, which is not always easy to do. Sometimes I have to get on the phone and say I am out of my league, which is just not fun. We weren't trained that way. And on the receiving side, the best conversations I have with an accepting doc, especially one that I don't know, which I get to know a lot of them that I'm calling, is someone who starts that conversation. We're going to take this patient. Let's talk about him, right? Which takes that sales pitch out of it. But I agree with you that the common traditional thing I grew up with, I mean, it came from the adversarial residency relationship of trying to get patients out of the ER times, right? Is the sales pitch, right? What am I going to do to make this easy to get this patient out? Even, not that I would lie, but maybe we will gloss.
I think part of that, I'll let you answer, Ani, but part of that is I think that that still exists. There still is from some centers this degree of, I'm going to say it's bullying, where they really make you prove why this patient needs to be transferred. So I get it when I hear this trying to sell, even though I try to assure them up front, we're going to take this patient. So now everything else that comes after that, you can feel relaxed and tell the story the way it really is. You don't have to oversell anything. But I still think there's a fair bit of that when I talk to other people, other places. Not every institution is just so happy to get someone else's patient from another institution.
I think there is another perspective to consider, though, and I'll speak as an accepting physician who sometimes has to manage a limited ICU bed number, where you do have to triage patients who do want to come into your facility for that higher level of care. So it is important to convey the reason for the transfer. It's important to convey why this patient needs to be transferred first, and they need the expert level that might just not be available at the other institution. And I don't think sometimes it's a matter of not being able to, it's a matter of just not having the additional resources that you need to care for that patient is the reason for the transfer. So it's important to outline that. And I think we're all pretty good at this as ER physicians and as intensivists to convey the need for the transfer. And I agree with what you guys are saying. Most accepting institutions are pretty good about taking those patients as fast as they can. But I think we've all dealt with the boarding issue. So sometimes there is a little bit of a triage process.
Yeah. And I'm going to jump in. It's a stylistic thing. When I accept a patient and I decide I need to bring a consultant on, after I've heard the pitch from Jerry or from whoever's sending it to me, I then take the responsibility to tell my consultant, who I usually know, what's happening. I almost hate that torture of like, all right, try your sales pitch again now, but now we have the CT surgeon on, and I think that's maybe it's stylistic, but I think it's a really courteous thing to do that builds that kind of trust that you guys are describing.
I think to answer your question, Adam, from the other perspective, most of us as physicians are, have this need to get off the phone as quickly as possible. So you
Yeah.
want to transfer a patient to me. Okay, thanks. We'll see you when you
Yeah,
get here.
I get it.
Right? That's kind of the thing we say. There is a fear of creating a patient relationship when you start giving some advice over the phone.
Yep.
But you have to realize that sometimes that advice is actually really needed on the other end of the phone. So if you can provide it, it would probably do a great deal for the patient.
No, that makes sense. I get that. Haney,
Yeah,
were
I
you
will
going to say
though
something?
that yeah, there's some times though where it is a good idea to get the consultant on board, because I don't know what the scope. We like to think when you're in a level 1 tertiary care center that you can do everything, but there have been times where I pulled the consultant on the phone. It's like, let me just get this person on the phone and you guys can talk shop and figure out if this is something you offer. And they're like, we can't do that here. What you're describing is not something that we can do. And forget about the risks of transferring patients. Sometimes just taking them out of their social circle, away from their family, to the big hospital, only to say the next day on rounds, yeah, we can't do anything. And in 2022, there's no reason that we can't do some of these things via telemedicine or just simply getting the person on the phone. We're deviating away from the original question, so I'll stop. But I just want to point out that sometimes, getting the other teams on the phone is tremendously helpful. And I've saved some families a couple trips to the big hospital just by saying, we're not going to do anything different. What you all are doing down there is just perfect.
Yeah, well said.
And it's also embarrassing when the helicopter takes off again after going from one tertiary to another. It never looks good. We do that. We do that a few times a year.
Okay, where should we go? So how about let's change direction a little bit and let's talk intratransport. So this could be from the community in or from ICU to ICU. What are the 3 most commonly encountered problems that happen in flight? That's oh my goodness, what do I do now? Or maybe you know what to do. But what are the three things that happen most frequently?
I think the most frequent thing is that whatever problem you had that you stabilized at the sending hospital goes bad again en route, especially anything that you temporized with difficulty. And so having parameters and ideas, like EMS professionals are great. This is what they do. That EMS mindset is all about solving problems. But if you already solved this problem and failed to sign out how you fixed it or what you were up against, whether it was recruiting a vented patient, whether it was blood pressure control, whatever hemodynamic problem you were suffering, having that conversation, and which is, I think, the big part of, and I know I'm old school about this, is the doc should be at the bedside when that transfer happens. And it is frequently not the case, and then that information goes. So I think that would be my number one. I don't think I could pick one catastrophe. It's more that whatever you were up against doesn't get better when it gets in a helicopter or an ambulance. And so that's what goes wrong each time.
I'm going to piggyback on that. I don't think that I've got necessarily a top 3, but I definitely agree. I mean, if whatever was causing the patient's instability, you have to make the assumption that if this were to happen in a transport environment, 1, will they be capable of dealing with it? 2, do they have the resources to deal with it? And then what? You have to think about the limitations of transport. So, when we do our resuscitations in our beautiful ICUs or in our EDs, resources come in from everywhere. And sometimes we have to get people out of the room, or there's just too much equipment sometimes. That's not necessarily going to happen in the back of the ambulance, where you have to think about, do they have access to the medications? Do they have access to blood? Do they have that specialty equipment that you need for transport? And those are all of the things that a sending provider needs to kind of think about for a moment before putting that person in any vehicle.
You're mute, Haney.
Thank you very much. So that leads me to something else I want to talk about, is what type of vehicles do we transport our patients in? Everyone loves to fly. Everyone loves to put people in the chopper and get them up in the air and zip them to the hospital as quick as possible. But anyone who's been in this business long enough knows that there's a cost that's associated with it. There are lives that are on the line. You probably know the data better than I do, but I know, looking through the news, at least once or twice per year, I see a helicopter that's gone down. And unfortunately, we have a tragic loss of life, not only the patients, but of very highly trained crews. So it shouldn't be a decision that's taken lightly, even though people love to do it. So my question ultimately is, what helps you with the decision to decide whether or not you want to put a helicopter or an aircraft in the air, or when is it a pushback to say, like, we really should conserve these resources for people better in need? Help me understand how to make that decision.
So I'll jump in on this. I think that some of the things to consider, and this is for whatever mode of transport you're going to choose, is think about, first of all, is it a time sensitive condition, right? You need to be able to answer that question. Number two, what is the transport time? So if you're talking about sometimes prolonged transport times, and some of my colleagues who work in more resource limited settings or where there's very long transport times from one hospital to another, taking that flight might actually be significantly better for patient care than putting them in the back of an ambulance for 4, 5, 6 hours. So these are all things to consider. And then, of course, weight, the amount of equipment, the amount of personnel required. You're talking about limited resources in the back of both of these vehicles. So all of these need to, I think, be taken into consideration.
Yeah, I think the biggest problem with that conversation is your local system. Ideally, in the perfect system I want to work in someday, is that the conversation I would have would be that 99% of the time I would pick a helicopter for time sensitive conditions. And that would be a very small number, which probably wouldn't support my HEM system. Unfortunately, or not for oddly system, that expensive resource is often used because I can get a higher level of training to a certain facility than I can get on the ground, and I can get it there faster, and not because 10 minutes are faster in the air, but because it can be hours waiting for that transfer ambulance just because of the system we have right now. We have huge shortage of providers. I mean, anywhere you work, you'll see patients waiting for discharge for days, right? Just because you can't get them an ambulance to take them out. And so because that adds a whole extra equation to it. But I agree with you completely. Like the weight of the patient, can you get them in there? How unstable are they? Could I actually resuscitate them in that small little helicopter? I mean, we have some really great big ones in the military, but most private helicopters is very claustrophobic. Every time I practice in one, I'm amazed at how tiny it is. And so I think those just really come to mind. Those, like, no, it's again goes back to that statement, which is frustrating for people. You have to know who you're able to call, and that's why I think in that conversation, as the accepting doc, talking about the things that you're worried about in a patient like this, especially if it's a less, if it's sepsis, it's sepsis. You guys are certainly better at it than I am, but it's not that. But if it's something that's much less common, talking about your concerns would help that provider pick the right ambulance.
We had a transfer a few months ago, and they were only going from Cooper right across the river to Penn. It was a transfer for ECMO. Like, we cannulated someone with VA ECMO. We're transporting them across, and it took them 2 hours to get the patient packaged up and put them in this helicopter. Now, I was going to go to the roof of this helicopter, and I've never seen an ECMO transport helicopter. I'm thinking it's going to be this gigantic space where they're going to be able to move in there. And when I saw them kind of crouch down, the perfusionist and the nurse and the paramedic in this thing, I was like, I had a greater appreciation for, like, you think it's helicopter, you think it's like this grandiose level of care. It's more constricted than the back of an ambulance. So I don't know always if people have this perception, like, get them in the helicopter. From a speed perspective, it makes sense, but I don't think if you're getting necessarily a better overall care, if I'm making a fair assumption, or tell me that I'm wrong.
I think you have to be very careful in making the assumption that helicopter is necessarily better than ground. I think you just need to know the resources that are available in your environment. So, for example, my ground team is trained just like a helicopter team, with the idea that they would be able to transition between both. So it's really important to know the resources that are available. There are definitely limitations, right? Size. I mean, not all helicopters are built the same. If you have a Black Hawk, you're going to do a whole bunch of stuff in there versus some of these smaller helicopters where everything waist down is inaccessible in the back of that helicopter. You just need to know what the limitations of each mode of transport would be. There's also weight limitations, so they can't take as much medication sometimes as you can in the back of an ambulance. So these are all things to consider.
Mm-hmm. And then there's weather. They're often just not available, which is the biggest headache. I think if you were to drop me in a random hospital and say, practice there today, and this will get me in trouble somewhere, if I had to pick and you weren't going to tell me any information, I would pick the HEMS helicopter, because it's very hard to find a poorly trained HEMS helicopter. It's much more variable on the ground, I think is a fair statement without getting into too much trouble. But there are some great ground critical care systems, and that's also, and there's a lot more they can do. I think that's the goal would be for every tertiary care to be able to send you either resources, and that way it would just be about how fast you could move somebody.
I think that this kind of leads to an important point that whatever system you work in, it doesn't matter if you're working in the ED, in the ICU, whether you're working in a community hospital or an academic hospital, really important to know the resources that are available in your community. How many helicopters are available? How many ambulances are available? How is the crew trained? What is their configuration? What equipment do they have available? And what are their limitations? And it's a lot, but that's what medical directors are there to help you figure out. So I would put in a plug, reach out to them if you have any of these questions, and they'll be able to help you and at least guide you to the right resources in the community.
Yeah, that's so interesting. I don't like. I think if you gave me all that information, I I would be confused. I wouldn't know what to do. I'd be like, that's like, oh wow, 25 ambulances. That sounds like a lot. Like, let's move some people around, you know. So, so I think that's so fascinating, and I I think I don't even know how to respond to that. I think I've never thought of it. And Jerry, what you're saying about, you know, not it may not necessarily be the speed of getting the patient to the facility that I know the vascular surgeon's not going to operate that night, but it's the crew that comes with the mode of transportation, and that a highly trained crew by ambulance may take 6 hours versus a similar crew on a chopper may come very quickly, even though that septic shock patient probably doesn't need to, it's not going to benefit greatly by moving them quicker to the ICU at the accepting facility. I think that's really fascinating. I've never thought about that. Any what other questions do you have?
Oh,
Do you have any, or you want me to jump?
Go ahead,
in?
hit yours. I got one dug up in here that I want to ask them. But
Oh, I got one. I have one. So I when I was a fellow, and you get called to this rapid response, and they're hypoxic, and you're like, all right, give me the rock, let's intubate them, right? And so we all do, and then you're in this small room and you're intubating, and then they have horrible hypotension, and then you're like putting dirty lines in, you're feeling all macho, and then you become an attending and you realize, wow, that was probably unsafe, and I should have just like moved the patient to the ICU where like Sam and Tony, my best bud ICU nurses, are hanging out. And does that happen in EMS? Like, how do you make that decision as when to move the patient or when you should just tube them and get going? Like, how do you? I'm assuming it's that same kind of thought process as, yes, they need to be intubated, but I think we could probably move them safer to the ER where there's all the resources ready. What's the process in your mind when you see these patients?
I think like what you mentioned is actually the process for most clinicians, right? That cowboy kind of mentality when you first started, mixed with the fact that when emergency medicine started RSIing and critical care started RSIing themselves, we kind of just did it. I don't know if we learned it from trauma surgeons or where, but we kind of, right? The resuscitating the airway was not something I was trained to do. And unfortunately, EMS is often a few years behind us because we bring those things out into the field, and so you'll see a lot of mixed patterns on which providers resuscitate the airway or just take it. It's a huge kind of it's a huge part of my job, and some days a little frustrating. But I think the same clinical idea, right, when you walk into that hypotensive, hypoxic, crashing patient, that same decision tree needs to be taught to EMS, and our best providers can do it as well as we can. But it's a lot of work, and it's unfortunately pretty variable.
Hey, so before Ani says something, that piggybacks something. Tell me about this King Airway. Why do you guys use it all the time, but we never use it? Like, what's the deal with this King Airway? When are we putting it in? What's the deal with this thing?
Well, you're 5 years behind the time. I'm sorry on that. No, I'm kidding. But so no, supraglottic.
I'm probably a lot more than that, but
but I was too. So this has been a change for me, and I always love when something I argue with my medics changes my practice. Right? Like when I have a patient, the airway's going bad, July is coming, right? The intern can't get the tube, and they're desatting. Right? I always put the BVM back on, or God, once back in the day, you just Hail Mary it, right?
Yeah.
But now I always have a supraglottic airway at the bedside, and that gets me out of Dodge. It also gets the intern a successful airway 90% of the time. And it, I mean, I don't enjoy it because it's very easy to do, but it's 100% a patient-centered outcome, right? I get control of that airway. I'm not bagging. I'm not trying to get a mask seal. And whether it's a King airway or my personal favorite is an iGel, though I don't get any money from them, um, it's new technology. I mean, the old LMA was just not that easy to put in. But these skills, I mean, there's places that EMTs are doing it and they have very limited airway training.
So are these all patients who there was an airway attempt that was unsuccessful, so they put a supraglottic in? Because that's what I think of when I hear supraglottic.
So not always. It really depends on your EMS system and also the kind of patient. So I would argue, and I'm not always popular for arguing this, that in a cardiac arrest patient, you should never intubate first. There's no survival. I mean, we're not even sure if you should intubate or use the supraglottic, but the supraglottic does not dissuade anyone from doing good compressions. And so it's mandated for our EMS at Cooper.
Understand.
But yes, in another airway patient, you'd often have it be a failed airway or someone who you needed to resuscitate, and taking the extra 10 seconds, or if it didn't go well, 5 minutes to intubate, you could really resuscitate that airway to the ET tube with a supraglottic, because you could immediately be bagged. You can immediately put them on the vent if you needed to. So it's not just, I think it's moving beyond a failed airway. I don't know. Do you disagree?
Ani, how about you? What's your practice and what do you teach your paramedics?
So I think, let me kind of step back and answer Adam's first question about the decompensation during transport. So let's say something goes wrong during transport. I think the difference between an EMS system and sometimes a critical care transport system would be that the patient is already identified as being critically ill, right? And sometimes has a whole bunch of extra devices like a balloon pump, an Impella, all this other stuff that they're traveling with. So most programs will actually have some kind of built-in plan for when the patient decompensates, because I can't take that patient to any community ED for resuscitation if I had to stop off somewhere. So all of that should be built in and should be discussed before crew members are actually live and active, just to kind of know what the plan is. In terms of these airways, so I teach my paramedics both the King as well as the iGel as well. And again, no stock in either company. But my algorithm for that is that that's for the failed airway. So they're taught to intubate. They get practice intubating in the ORs with our anesthesiologists. And they do this probably more often than they would have done in the EMS system. So they do hopefully on the order of about 20 tubes in a year. So they're hopefully going to be ready just in case these high risk intubations need to occur. But when these fail, there has to be some backup plan. And that's when we use our supraglottics.
Makes sense.
Interesting. Nice to see that there's two both very good medical centers doing slightly different things, but always kind of falling back to safety. That's very interesting to hear. I want to round it up because we're coming to the end of this, but I want to round it up with a question that it's kind of a corny question. It's a question that all of us get asked at cocktail parties by non-physicians. But being that I'm not in this world of pre-hospital, I'm going to ask that same sort of fanboy question. For each of you, what is the craziest case or transport case that you have either been involved in or, one of your teams has told you about? And obviously no names, no details. Theoretically, what would be the craziest story that you've ever heard about? No,
Sure,
Josh
I'll let
put
you
his
go
hand
first.
It's
up.
helpful.
You're both kind
It's
of looking
helpful
away.
if you,
This means that there are good stories on deck.
Yeah, it's helpful if you give a little, like, set the mood a little bit, like be like it was a Tuesday night. The season was fall.
Yes.
Like give us a little bit, like.
I was at home drinking a White Claw,
Yes.
and then I got the phone call. The phone rang.
All right, so I'll give you I have this story because all people want to do is ask you for that story, and like nothing we think is fun or interesting it's just gross for all of my friends. So I'll tell you my one good story, who the patient did not survive, even though in the end. But as a brand new paramedic in New York City, I was led into a Broadway theater right around showtime. Was led in the back, which is weird. Usually they just drag the poor guy who passed out so they can restart the show. And they lead me onto the stage. And it's cats, which dates me a little bit. And there's all these strange cats milling around. And there's a very large man who is in the upper rows on stage in cardiac arrest, who, through some miracle, we got back. And a very nice, I'm not sure exactly what kind of physician who was like kind of at the feet, screamed, "I have a pulse," feeling his feet, which was great. He wasn't a podiatrist, I don't think. But, and the crowd got it. And so the most awkward thing, I don't belong in show business. As I look up trying to figure out what to do, I've been a medic for like 6 months. The entire crowd starts clapping, and it's like a big, big room. So that's my most.
Did you take a
weird
bow?
EMS
That's the
case.
question. Did you take a
And
bow?
that is the
and
embarrassing
exit
point,
stage
because I did not take the bow.
Which is interesting because oftentimes I'll play dead at home just to see what my cats will do. You know, just to sort of test out, see what they do. My cats are not like those cats. My cats just walk away. They could care less. But these cats, they seem to care. That's really heartwarming.
Actually, no cat did CPR.
Oh, well, then it sounds just like a cat then. These bastards. Dogs would cry, they'd whimper, but freaking cats, they just don't care. Ani, how about you? Let's hear a good.
So I'll tell you guys a funny story, and I'll kind of make fun of myself a little bit. So I went on, early on in our program, we had started doing some mobile ECMO transports. So our entire CT surgery team would go out with our team to cannulate in another hospital, bring the patients back. And we were down to just one crew member. So I decided that I would kind of go on the transport, help them out. And, when I get there, the patient's already cannulated. So the CT surgeon at this point steps out, defers the resuscitation to me, knowing who I am and knowing that I'm able to do it, which was great. So trying to help the paramedic and to stay out of her way, she gave me a whole bunch of IV tubing to hang on to as she's trying to coordinate the movement from bed to stretcher. And there's probably on the order of 6+ pumps at this point. And I don't know how I did this, but within seconds, it becomes like the spaghetti thing, which I then tuck underneath the sheets. But as soon as we got to the ICU, I told the nurses, I did that, so please just help me untangle that.
That's awesome.
It's much easier to do than you would think.
Yep.
Totally.
That's amazing. When they took that patient out, that ECMO transfer, part of the reason it took 2 hours from when they got boots on the ground to transporting out is because of how meticulous they were with the lines and labeling it. And I'm sitting there, I'm just like, just get this patient out of here. And they're just like, we're just following this line and hooking it up. I'm just like, dear Lord.
It takes practice. It takes practice.
Yep. And again, in that tight setting, it makes sense that you want to take time and know where everything is because it was a 2-minute flight. It was a 2-minute flight. I just get that's how it goes, I guess. That's how it goes. Let's go ahead and take some questions from the audience. There were a couple good comments here. We have Ian London. Ian London looks like he's in the military. And he's saying that the medical helo aren't as stacked, but it provides a little bit more space. Which does that sound? Have you been on medical helicopters? I'm sure you've seen schematics for them in part of your training. Yeah.
Bigger.
Yeah, I dream about having a military aircraft. It would be amazing. It's like a party.
So that's actually another important thing is that you need to make sure that the helipad can actually withstand the weight of some of these helicopters. So that's actually another important consideration.
When I was up at Dartmouth, there was a bariatric patient who were transferring from a critical access hospital, and they had to get a Chinook helicopter. I mean, we were waiting on a Chinook, and let me tell you something. When that helicopter landed, the whole building vibrated, and it was just incredible to see like this big cargo door bay open. For those of you who don't know what a Chinook, because I didn't know what a Chinook was till that night, it's where they load the tanks and the artillery on these things. It was just impressive to see this person slide out. I assume they had enough room to do what they needed to do on that Chinook with that patient.
Haney, that's the one I want. If I need to go in a helicopter, I want one of those. Okay.
Okay, got you. I'm gonna start getting the phone numbers for that right now.
He requested, Dr. Green's requested a Chinook, please.
It's not easy to do. Get a Chinook. It took a few hours just to find a helicopter. Let's see. Sham, who's a good friend of mine, says in my helicopter when I was flying, we sat next to the patient, not above the patient's head. We kept a set of king airway below our seats so we could grab it and place it blindly from the left of the patient. That sound about right in terms of setup? Similar?
It's different, but I would do it that way if that was my if that's the constraint you have. I think that's great.
Yeah.
Yep. I think it depends on the setup of the helicopter as well.
Okay, cool. Adam, you know who I have here on chat?
Is he here?
He's here.
Oh my gosh. Whew. I was worried.
Randy. It's too much detail to go into who Randy is, but Randy's always here, and Randy always comes through. And so Randy's comment is, uh, when do paramedics decide to stop CPR? Sometimes we'll get a patient with some crazy downtime, and I wonder how EMS is taught to deal with the end of life in the community. So, when to terminate, I guess.
So, again, to make big generalizations wouldn't be fair. You'll still find some systems that don't pronounce in the field at all. Usually in a transfer situation, that's a little less common. Usually you're going to resuscitate and continue the transfer or divert locally, depending on what you're up against. But in the field, if you're resuscitating, a few systems have moved to not doing any resuscitation on people with poor prognostic factors like unwitnessed or asystole on an arrival. In our system, generally we will work we'll work almost every arrest. But after 20 minutes, if we have persistently low end tidal CO2, asystole throughout, it was unwitnessed, and there's no good prognostic signs, then they'll terminate those patients in the field. And then the second question is huge, right? The death tell, or however you like to term that, is something that I never actually got any formal training in, but got better with over time. And it's really important to do well. And it's very variable what our EMS providers get as far as that education. It's something I try to model when I'm out training my people, but I don't know. And some paramedic programs teach it, others don't. Mine certainly didn't. And so I think that's a work in progress that we need to get better at.
And Haney, if you don't mind, go ahead.
Sorry, Adam. I think to kind of piggyback on what Jerry was saying, it definitely depends on the system in which the paramedics are working. There are some protocols that actually tell them exactly what to do and when to terminate. And of course, this has all changed with COVID and the pandemic, and they've been given some liberties that they didn't have previously. I will tell you that in a critical care transport environment, that is a little bit different. I do have these all built into my protocols about when they can terminate, how they can terminate, and it's usually just continue resuscitating until you get to a different hospital. But this actually brings up a really important point, that as a sending provider, you absolutely need to give the transport team the correct information about the code status of the patient. If they're full code, I don't allow them to terminate during transport until we go to another destination hospital or somewhere to stop off to continue resuscitating the patient. If they are DNR, DNI, then I ask my providers to make sure that there's a plan and they know what to do should the patient code. So that's really important that you make sure you convey.
Those are great points. And when those decisions are made, are they autonomous because there's protocols in place, or is there a call to either the medical director? I'm trying to figure out who would make that call. Is it the receiving hospital, the transferring hospital, the neutral medical director?
In my case, They call either the receiving provider or me.
Okay.
But again, you need to know who they are directed to call in the system. And I don't know, Jerry, if you have anything different from EMS systems in general.
I mean, I can't think of that. We've certainly had people go into cardiac arrest, but we've never actually had someone pronounced in between facilities that I know of. I'm sure maybe before my time. But in our system, they would call the emergency department as their home base, since that's usually where they go first. They could also talk to the intensive care team. They have you guys on speed dial, but generally they would call the ED for that kind of guidance. Or if it was a very special case, they would 24 hours a day, they can wake me up. We have a special line for that as well.
And I'm assuming, Jerry, that there's a period for these out-of-hospital arrests that the EMS crew works on them in the field and at some point makes a decision to transport while doing CPR. That there's probably an initial resuscitation at the scene, right? Is that correct?
Until you get me some good ECMO data and a great system, then we'll change that. Yes, we resuscitate on scene, and when they get to 20 or 30 minutes, or especially depends on where did you go down in the middle of Walmart, or are you on the third floor of a walk-up with no elevator and you're 400 pounds, and it'll be not that we won't do that work because you're overweight, but because there'll be no resuscitation for the time that you're extricated. All of those come into play about how long we stay on scene and whether we transport at all.
Yeah. Jerry already knew that I was going to say all of those out-of-hospital VFib arrests should be immediately brought to my ER so I could put them on eCPR. He already knew I was going to ask if that plays into it. And I'm sure, right? I'm sure if you have an active eCPR program ready to cannulate, that may change how you build those algorithms.
I'm ready to do it outside too. You just talk.
You,
Same here.
And I'll get the Chinook in case we need it. So,
oh, come on.
yeah, definitely Chinook. All right.
All right. Is that all? Are we ending with Randy?
I think Randy usually steals the show, so we'll leave it on that since we've been off for a while. But
well, I just want to say thank you. I think this was something different, and I really enjoyed it. I thought it was a special show, and I love learning from you guys and hearing the different perspective, but somehow still very similar.
Yeah, I think many of our listeners, clearly people like Sham and Ian, they do pre-hospital work, but there are plenty of people who are going to listen to this who really have no clue about what happens once the patients leave their care or when the patient's in transit getting here. I learned a ton of stuff, and I'm grateful that we had two pros on here, and hopefully we can get you back sometime in the future and keep expanding this conversation, and also get some actual pre-hospital folks on here to give their experiences as what they for what they do. But Ani, Jerry, I just thank you so much for being on here with us tonight.
Thanks for having me.
Thanks. It was super fun.
Have a good night.
Thanks. Bye.
All right, Adam. I'm trying to switch back here. This thing is finicky today. I think it's been so long. There's like rust in this pedal over here, and it's not clicking so well. We can't go too long like we have on hiatus from the lounge.
Absolutely. So, go ahead.
No, what do we got next? Since we're talking about hiatus, we kind of put our heads together, got our act together, and we're going to be a little bit more consistent and regular.
Yes. So June 15th, and I'm giving the caveat that we may change, but likely set in stone. June 15th, same time, 7 p.m. We're going to be talking about right heart failure and ARDS. And I can tell you the guests are phenomenal. So I don't know if I want to spoil it completely, but I think it's going to be one of the best talks we've had yet.
You've said enough. You've whet their appetite. You've made them curious. June 15th, we're going to be talking about RV dysfunction and ARDS. It's almost set in stone, which is like the chisel is out and the hammer, and you're about to, but we will update you all very, very soon. Be sure to like and subscribe to the channel so that you can get alerted whenever we go live and whenever we have a next show planned. But put on your calendars for June 15th, right? June 15th, 7 p.m. Over the next couple of months, we're going to be changing up a little bit. We're going to try different times and dates just to make sure that it's all good for people. This seems to be a good time, but who knows? Maybe you all like to hang out 3 p.m. on a Tuesday. We don't know, but we'll try things out and see what the consensus is. But Adam, always good to see you here on the lounge, and thanks for some great content. I appreciate you.
Absolutely. Thanks, Andy.
All right, everyone.
Until next time, buddy.
Thanks for watching. Like and subscribe, and we will see you on the next lounge. Take care.